Welcome to Patients at Risk, a discussion of the dangers that patients face when physicians are replaced with non-physician practitioners. I'm your host, Dr. Rebecca Bernard, and I'm joined by my co-host and the co-author of our book, Patients at Risk, The Rise of the Nurse Practitioner and Physician Assistant in Healthcare, Dr. Nuran Alajba.
Good evening.
In recent years, there has been a massive increase in medical practitioners offering hormone therapy to patients. Since insurance doesn't cover these treatments other than for very specific medical conditions, most patients end up paying cash, leading to big profits. These treatments are usually promoted as wellness products intended to make patients feel younger, stronger, thinner, and just all around better. But the truth is that there is no clear evidence that hormones for wellness really cause any of these benefits. And when used improperly, hormone therapy can cause serious risks to patients and can even cause death. Today, we are being joined by Dr. Joyce Varughese, a gynecologist oncologist. As a doctor treating women with gynecologic cancers, she has seen serious harm caused to patients from using unapproved therapies, and she's here to share some really important information for patients. Dr. Varughese, welcome to the show.
Thanks so much for inviting me.
Can you start us off by just explaining what a gynecologist oncologist is?
Sure, it's a long term. And so basically gynecologic oncologists, we take care of women with cancers of the gynecologic organs. So that's the uterus, the cervix, the ovaries, the vagina, and the vulva. We also often take care of women with precancers, also of the cervix, the vagina, the vulva, sometimes of the uterus, or something called hyperplasia when it's in the uterus. In order to become a GYN oncologist, essentially after medical school, you do 4 years of an OB/GYN residency and followed by 3 to 4 years of a gynecologic oncology fellowship. After that, essentially to really become a board certified gynecologic oncologist, you have to take 2 standardized written tests and 2 standardized oral exams because we are board certified in both obstetrics and gynecology as well as gynecologic oncology.
You know, when I'm sending my patients to gyneco-oncologists because they have either cancer or I'm suspicious of cancer, I usually tell them these doctors are just about the best surgeons that you can possibly find because you guys have been trained to operate not on normal anatomy, well, that as well, but on people who have really distorted anatomy because of these kinds of cancers. And so you really have to be really good at what you're doing. So, and that took a lot of training to get to that point. So I applaud you for going through all of that and thank you for what you do for patients.
Thanks so much.
So, are you seeing a lot of a rise in women coming to see you because they have been prescribed some of these hormone therapies? Or what are your thoughts on hormone therapy as used for wellness?
Sure. So just for everyone who's listening, I am a GYN oncologist and I prescribe hormones for my patients. I think that hormone replacement therapy is a crucial piece actually in improving women's quality of life, even after cancer treatment. So there's a lot of data out there on hormone therapy that it's, there's many benefits for heart health, for brain health, for bone health, and for quality of life. So I'm not an anti-hormone doctor by any means. However, I am anti non-evidence-based treatments and things that are promoted as wellness or preying on women's insecurity is not a great word, but it's sort of, as women age, changes occur naturally. And what I think is really important is that women understand that these are natural changes that occur and there are evidence-based treatments that can help them. Now, what my issue is when people who don't need these hormones are then touted, are advertised as, you can feel better with these quack therapies, truly. One of the things that I've seen, and to be honest with you, I only saw it within the last 4 to 5 years. When I was in training, I actually had never encountered these pellets that are being inserted and they're being advertised. And what's really scary about these pellets, though, is number one, some of them just have estrogen, are advertised as just having estrogen. Some maybe have estrogen and progesterone. Some have testosterone and estrogen. It's sort of, really like Russian roulette as to what you're getting or what's being advertised and what's being given. And what they are just a small little, like kind of almost like a grain of rice pellet that's introduced into like the buttocks muscle by these practitioners who are, offering them. And these are not, not paid for by insurance. So women are paying out of pocket. But why I see these patients is because they then develop hyperplasia or precancers of the uterus, and in some cases, actually cancers of the uterus, because the uterus needs both estrogen and progesterone. Progesterone essentially kind of stabilizes in a very simplistic manner, stabilizes, while estrogen leads to growth of the lining of the uterus. That's a very simplistic overview of the hormones of how they affect the uterus. But what's important to know is that a lot of women will say, well, I didn't get any estrogen pellets, I just got testosterone. But testosterone gets converted to estrogen in the fatty tissue. So it's why, as I discuss it with patients, I say that it's sort of like why when you see really overweight men, they look like they have breasts, right? Like, or man boobs is like kind of the layman's term, right? That's not just fatty tissue. That's actually their testosterone getting converted to estrogen in the fatty tissue and stimulating their breasts to grow. So I have this discussion on a daily basis with my patients with uterine cancer, because obesity is a risk factor for uterine cancer. And so I talk to them about how testosterone gets converted to estrogen. But in terms of these hormone pellets, this testosterone that we don't know how much is in them, we don't know if there's any estrogen in them, we don't know if there's any progesterone stabilizing the uterus, stabilizing the lining of the uterus. And so it can lead to this overgrowth leading to precancer or cancer. And that's how they then come to me in the past several years, that I've unfortunately been treating these women who really probably would never have needed a hysterectomy. I mean, then they need surgery, which has its own risks, and then potentially close follow-up if they did have a cancer.
So I have a couple of questions, and I'm going to go from the dumbest question to probably then the more informed questions as we go along. I'm a pediatrician, so nobody's doing any pellets in anywhere in my practice, just to be fair here. So could you say that again? Like, I remember Suzanne Summers used to do something funny with estrogen, right? She used to either topical or put it in her vagina or something.
She was the one that started that whole bioidentical hormone discussion, didn't she? Or she popularized it.
Is this different? Like, I actually have no clue. I've never heard of pellets, and I'm not sure where you just said they put them, but I think that's the dumb part of my question that I need you to answer before I can ask you the more informed part. So could you explain this pellet thing? Because I'm completely lost.
So this pellet thing, so literally if you Google like hormone pellets, depending on the person who is providing them, so there are some where they say that they specifically compound them and make, check your hormone levels and do a whole bunch of tests, and they specifically personalize them. I am a big fan of personalized medicine. I think, it's actually the future of cancer treatment, right? But so they basically personalize whether you need a touch of testosterone, a little more estrogen, and maybe a medium dose of progesterone, and that's what they...
not really something that they can really determine, right, Dr. Varughese?
No, and nobody can, right? So in the sense that they can say that they're giving anything to you and there's no accountability, right? Nobody can hold them to yes, they put this much into that pellet and now they're inserting it. It goes into usually into the buttocks muscle. So the gluteus for those, medical folks who are listening.
Like injection?
It's inserted. It's kind of like no, like in the subcutaneous tissue.
Oh, okay. Okay. Sorry. Yeah. I got it.
Yeah.
And then who's making them? So I'm assuming when you say, okay, let's just say it's a third testosterone, 2/3 estrogen, just for simplicity's sake. Is there a person that's writing for a compound pharmacy to then make could you explain that a little more?
So there are companies that make kind of standardized pellets, I guess, if you want. And then there are, this I actually recently learned of because I literally Googled it and I found certain practitioner, I don't even want to use that word, but certain people who make their own, create their own compounded formula.
So not regulated then by, say, a standard compounding pharmacy or anything along those lines?
No.
And you're saying that essentially there are, I don't know what to say, clinicians, because I don't even want to say practitioners, like you said. So no one is overseeing this. Is that what I'm understanding?
Yes.
And then the other thing, Noreen, is once they're in, they're in. You can't just take it out because it starts to dissolve. And plus, how would you even find it necessarily? It's not like when you get the Nexplanon in your arm for birth control, then you can take it out. It's a little rod. These pellets just are meant to dissolve and you can't find them. So now they're supposed to last, I don't know how long, like what, months at a time or something?
The ones that I've seen have been anywhere from 3 to 6 months that you're
Mhm.
supposed to
So it could be a
get them
walking
again.
dose. And I actually had a patient of mine, I know a little bit about this only because one of my patients came to me after a pellet. She was having ridiculous vaginal bleeding. And then it turned out she had endometrial hyperplasia, which is a
Makes
precursor to
sense.
endometrial cancer. She
Right.
actually did not have any health insurance. So she was seeing this practitioner and paying cash for it. Then she comes to me. I'm a DPC doctor, so I take care of a lot of people without insurance. And I say to her, listen, this is not okay. This is not good. You cannot have this kind of bleeding. You're 55 years old. We have to get this checked out. So now she has to come up with money to go see a gynecologist and end up having to have, I think she had to have a DNC or something like that. And it ended up costing her quite a lot of money, but it was all because she was seeking this like wellness and vitality and that sort of thing. And I don't think she understood the risks that could have happened.
And can I ask one more kind of dumb question, again, from the pediatrician in the room here? Why not just go on birth control pills? I mean, and I'm only suggesting that. I know, like, my mom went through menopause. That's my big experience, right? And my dad was an endocrinologist, so I've got some knowledge here. But, she was on an estrogen patch for years because she said her hair was more full, she had less bone loss, she just felt better, and it was regulated by her regular MD physician in some sort of lower dose. So, I mean, why not just do the standardized thing like that? Then you are getting estrogen and progesterone, like you said, in a little bit more of a physiologic way.
And I think a lot of that is because the public wants these bioidentical or more natural
Okay.
forms of things. But absolutely, like I said, I am not anti-hormone in any way, shape, or form. I prescribe hormone replacement therapy all the time for my patients. And there are FDA approved, regulated forms of it. And there are multiple different forms of it. In fact, there are even forms of testosterone that are approved for women. Like there's a combination estrogen testosterone pill, so it's not that those aren't available. It's just that, again, it preys on the public's perception that these are more natural in some way, or more, these bioidentical hormones. And again, there's just really no data suggesting that those have any less side effects or, any greater benefits than using the ones that are FDA approved.
But can you clarify this whole bioidentical versus synthetic at all? Shed any light onto that and help patients understand that really the prescription medications are probably safer, better, more monitored than something that somebody's just kind of whipping up themselves?
Right. And so, exactly. So, you said it, Dr. Bernhard, right? So it's really that, I could go to my kitchen right now and whip something up and say it's bioidentical and sell it, right? Like, I joke around, I'm going to like, when insurance companies piss me off and like aren't approving things, I like joke around with my staff. I'm like, I'm going to hang a shingle saying Joyce Varughese, MD, naturopath, or like, whatever, cash only, because sometimes I get it, but I just in good conscience would never do that, right? Like, but I could whip something up and say, I'm selling bioidentical stuff for you. And I mean, it could be some herbs from my garden and like,
Can I ask you what your patients say to you? So, you get a new patient, they have, let's just go with endometrial hyperplasia, because that is something that a lot of people are familiar with, bleeding after a certain age, et cetera, and usually precancerous or indicative of cancer. So what do they say to you when you say, wow, I suspect this that you've been doing with whoever you've been doing it, contributed to this? Like, what do they say to you?
So I have to say, so most patients actually are not even aware of the risks. I actually just recently, within the last 2 months, had a patient, the exact scenario you just said, that she had really no other risk factors for developing uterine cancer and had been taking these pellets and all. And so she was very receptive to what I said. And she said, look, do I need to report this? She was actually one of my only patients that said, is this something I need to report or anything? But she had not been made aware of the risks of it. And so whether this is all placebo effect or probably not, because there is some hormone in it because it's changing the lining of their uterus, right, for some of them. So they feel better on it, but probably because they're getting some estrogenic effect, and they would feel better if they were on, any sort of estrogen or, hormone replacement therapy. So, so they are some are receptive, like this, my most recent patient. Others are like, the folks who are selling these things are I find are very charismatic, very, I want to say have an hour to sit with the patients and kind of, quote, listen to them, but really are selling them a product, right? And so people are, like that, right? In a sense, like they feel like they're being listened to, they're getting this whole personalized, approach to their symptoms. But to be honest with you, there's a lot of data that, yoga helps with menopausal symptoms, right? There's a lot of other things that are, including hormones as well. But, there are a lot of other ways that women can manage these symptoms, but they, that require a bit more effort than just going and, getting a pill or getting a patch or getting a pellet.
What you say makes so much sense to me when you talk about how, well, first of all, we're always looking for something to make us feel better, especially in today's day and age. We're so stressed about everything and we don't eat right, we don't sleep right. So, I want something that's going to make me feel better. So we all would like something, and we may just be a little more susceptible to falling for those sales tactics because we really want it to be true and we want to believe in it. But the other thing that is a good point is that they have time to sit and talk, and doctors often do not, because especially if we work in a system where we only have 7 to 10 minutes with each patient, patients aren't going to feel as listened to and heard. So I think that's just a problem with our broken system. And the other thing that you kind of alluded to, the whole insurance thing, I see why a lot of doctors and non-physicians are going into cash type practices, because they're so burned out with dealing with insurance denials, prior authorizations, that they're looking for some way to get out of that. And it's tempting, but it's not the answer, because this is not good for patients. This is not good quality care.
Exactly. No, absolutely. You hit the nail on the head, right? Like, I completely understand why people are moving away from working within a system or taking insurance, because, like I mentioned, I bang my head on a wall, trying to get certain tests that are nationally following national guidelines, and I still can't get approved despite me trying to talk with, folks at the insurance company. But above all, do no harm, right? And with there are, especially when there are safe alternatives, this really just doesn't make any sense to me.
So who's doing this again? Because I'm sort of like blind on this whole issue. I mean, is this MDs? Is this DOs? Is this non-physicians? Is this naturopaths? Like, who, chiropractors, like, who is doing this, or who do you see in your practice? Who are those patients seeing when they're seeing you for cancer? Like, who is their person?
All of the above, essentially.
Wow.
Truly, it's all of the above. So it's funny because one of my first patients who really prompted me to look into this, because I was like, what did you have injected? What was that? Where? And unfortunately, I found out that was being done by a board certified OBGYN, and so, but if you just search, I mean, there are, you don't have to really even have a medical degree to be doing this. You can be a naturopath or a chiropractor, or just somebody who has access to these companies and is willing to sell them.
So have there been any sort of, I guess, investigations? Or I can tell you in Washington State, there was this whole thing in about 2013 to 2015. They took away the medical licenses of probably 5 to 10 different doctors who were using human growth hormone for, it sounds like bodybuilding maybe, or a couple of other ways. They didn't even show patient harm, although I know growth hormone also can be, neoplastics. So we need to be careful of all those things. But again, they suspended them summarily, at least for 3 to 5 years probation. So is that what's happening where you are? Or is it just like, this is an unchecked kind of thing going on?
I haven't heard of anybody losing their license for doing this, to be perfectly honest with you. And part of it is probably that they document patient counseled, blah, kind of on potential risk. I really don't know, but I don't know of anybody who's lost their license because of it. And again, many people don't actually have licenses who are doing this. So what regulatory board are you really going to, report them to? And the other thing is, it's not enough to show that you've deviated from the standard of care in most states, right? You have to also, like, for a lawsuit to really go to fruition, you have to also show evidence of harm and quantify that harm. And the issue is that some women develop uterine cancer and we never find a reason, like just completely sporadic. And so it's really hard to necessarily, like in the court of law, to prove causation, to really bring it to that point.
Yeah, when we had it in our podcast some time ago, we talked about the case of Kevin Morgan, who was a nurse practitioner who was prescribing testosterone like crazy to men, and several of them died. And it took an incredible amount of effort to get his license removed. And I understand he's in the process of trying to get it back. And that was after we had deaths that were definitely associated with that. So I think it's going to be really hard to shut this down. And I think it's going to be really hard for patients to get justice if they are harmed. And I think that's why it's really important to raise awareness about this. And patients need to ask questions, and really they need to seek out, obviously a physician and maybe even a second opinion if they're not sure. And if something isn't covered by insurance, it's probably because it's either not considered standard of care or it's considered experimental. And people really need to be skeptical about those kind of treatments.
One of my, I have not personally seen this, but one of my colleagues, I think complaining to her in the OR because it was actually this patient who I'd recently seen who had the estrogen pellets. And I was like, I can't believe I'm like doing this hysterectomy, like kind of, this could have been prevented, and she said that she had actually seen a patient who had these pellets and had actually developed a micro penis, basically enlargement of the clitoris enough to cause like a micro penis because of the levels of testosterone she had been receiving. And she said that ever since then, she brings it up to her patients who, if they ask her, like, what are you thinking? What do you think? I was thinking about, I saw this person and I'm thinking about getting these. And that's something that's not just reversible. In some ways, hyperplasia or uterine cancer are almost, are not so bad. And when you think about that, because that at least is curable with a hysterectomy.
As compared to growing a micro penis. I didn't even think about that. Now, what I usually tell my patients is think about things that men get, like hair loss, facial hair growth. I say, we got to think about those things. But now I'm going to add micro penis to that list of discussions.
Yeah. I mean, it's like, I take care of women who have testosterone secreting tumors, sometimes of the ovaries, and you see clitoral enlargement. Their voices get deeper. They have like male pattern, like baldness. But to have that kind of done because it was, a testosterone secreting tumor, at least once I remove that ovary and with that tumor, their testosterone levels normalize and like we get that taken care of. But this is a pellet that nobody can dig out. Like, who knows how much longer they're going to have that testosterone floating around. So when she told me that, I was shocked because I've never seen that. But it's one more thing in my armamentarium to talk to patients about.
And what's the thought? Again, one last question about this kind of, hypothetically. I know I have patients who've done topical, right, on their skin. I had one case, this is quite a few years ago, where both kids that were like way pre-pubertal developed breast growth, essentially, or gynecomastia. And we couldn't really, I went through everything. And finally the mom was like, well, I do have this topical estrogen I'm using and I do snuggle the kids at night, but I wait, like I put it on. I don't really understand all of it, but she put it on and then she'd wait like an hour or whatever it was. Well, clearly some of it was rubbing off on the kids. So obviously when I'm like, okay, stop that, their breasts went away, they were like 8 and 6 or something. And so again, what's the thought? I mean, just a pellet, you don't have to put it on. Is that kind of the thing? You just, instead of having to rub it on?
Yeah. I mean, it's like, it's good for like 3 months, right? It's sort of like,
Depo. It's
like Depo. Exactly. Right. It's just like, you do it and like, you forget about it. It's like the IUD. It's like, all of these, longer acting things that you don't have to think about something every day or every week to remember to do.
And it's also sold to patients like it's the greatest thing since sliced bread. I mean, the things that my patients come and with their promise that they are going to all of a sudden lose 50 pounds, they're going to look so much younger, their sex drive, a lot of women come to me with concerns about their sex drive. So they're definitely sold on the libido issue. So they're told if you get this pellet, you're going to have all these amazing side effects from it. So that's why they do it, I find. And I want to talk a little bit about that whole salesmanship, because when we were talking about this with some of our physician colleagues on social media, there were some comments where one OBGYN said that she was at a conference and there were spokespeople for these pellets and for different hormone therapies. And she said, quote, "They make it sound so glamorous and scientific. Sadly, many physicians and mid-levels lined up to learn more about it." And another one said that a compounding pharmacy came to her office and visited her and told her about how great it was. And when she asked, well, what about the increased risk of cancer? The pharmacist just seemed to look at her blankly and didn't seem to really be aware of any increased risk. So I think that there's definitely a lot of promotions. But the thing that really worried me the most was we talked a little bit about the elite nurse practitioner before. And this is a nurse practitioner who has a goal of helping other NPs set up their own cash-based clinics. And he has all sorts of different courses, but one of them is the Women's Health and Hormone Replacement Therapy course. And so what it says is this course is designed for the nurse practitioner who wants to open a high revenue, low expense practice that can be done part-time, or for the nurse practitioner who simply just wants to learn about the most in-demand women's health topics. And then it says women's health, especially hormones, has been a very hot service line for years and for good reason. And then in all capitals, women want to feel better. And what does that mean? High profit potential for the astute nurse practitioner entrepreneur and making an impact on the health of the female population. But I mean, they're laying it out right there. And then they go on to say that one of the best parts is that it can be done on a part-time basis and, quote, the aging female demographic, which that includes me. So the aging female demographic are willing to drop cash in capitals cash on these niche service lines, which results in a high revenue practice that can be done in only 1 to 2 days a week. And then it says, I'm sorry, I got to keep reading because everything is just more and more shocking to me. This course will teach the nurse practitioner who has zero experience with women's health, zero guys, zero, and hormones, how to practice this niche service line and how to open a practice from the ground floor. And it will teach you everything. And then you mentioned, Dr. Varughese, about how they have signing consent forms and say, you know, that they understand all the risks. And so one of the things that this includes is nifty treatment protocols that you can use as a quick reference. And also they said that they have how to create bulletproof documentation to CYA, and CYA means cover your ass, for those of you who don't know that acronym. So this is all about how to sell and capitalize on the aging women demographic. And I'm very insulted by that as part of that demographic.
Well, I'm very insulted by it because let me tell you that even after 4 years of an OBGYN residency, in your first couple of years in practice, you're still, I mean, there is such nuances to hormone replacement in terms of, you know, do they have a uterus or not? Do they need the progesterone or not? Like, you know, it's, and is it sex drive that's the problem? Is it vaginal dryness? Is it vasomotor symptoms? Like, do they need testosterone in addition? There's so many nuances to it that it's one of the things that I find that like junior OBGYNs actually look to their more senior partners for like advice on for those first few years, you know, because it really is a very nuanced thing. So I'm insulted because, I mean, despite all my training, I'm still like, you know, there's still, you know, newer products coming out that are FDA approved that I'm still having to learn about. There are newer non-hormonal options, which are great for some of my patients who can't use hormones because of certain prior cancer diagnoses. And so it's, you know, but instead I could learn this in how many hours of a course is it? You know, it's just like, I need zero experience and then I can like learn all of this. It's just, it's scary that somebody who goes through this course is then being unleashed on the public because—
So you're about to get really mad now because I just found it. It's 4 hours.
And it's $499.
Yeah, it's a 4-hour course. And somebody that knows absolutely nothing, he says, about women's health is going to now be certified to use hormones that we know can cause cancer, can increase cardiovascular risk, can cause micropenises. There's a lot of bad things that are involved in this, and you're not going to learn it in 4 hours. And it took you many, many years to learn how to do this properly. And you're right, it is insulting.
I do want to say this. And maybe I'm wrong and maybe I'm old fashioned. I'm, third generation primary care doc in a small area. So bear with me, but it's really a sign of a completely shattered system. It's not even broken. It's like the glass is on the ground and now people are jumping up and down on the broken pieces of glass they're turning them into these tiny little splinters. And I guess my thing is I really hate selling stuff. Like, I think it's totally different. The DPC docs do their own medications, right? And they charge to cover the cost of their medications. And I, depending on what I'm doing, will sometimes do the same if I've ordered a bulk medication for someone and I'm handing it out. Sometimes I don't even charge them at all because I do it much more rarely. It's just not worth a couple dollars. But the thing is, I don't sell vitamins. I don't sell minerals. I don't sell stuff because for me, and again, and this is no insult to anyone else, if you sell something that you really like or whatever, I mean, I make recommendations. I say like, this is a great book with recipes for baby food. This is a great this. I get no kickbacks. This is the vitamin D I use on my own kids. It's liquid. It's easy to give. Really simple things. But what bothers me is I don't want to sell you products. I don't want to sell you on me. I hate that. And I see that happening. And I guess it is just a sign of a broken system. But I don't know. How do you feel about it? Just being where you are seeing these women that have been harmed by this stuff.
Right. I mean, again, I think it's that, I think the DPC docs, though, for the most part are still following evidence-based guidelines. It says Dr.
100%.
Bernhard said, right? Like,
100%.
If insurance doesn't cover, it doesn't normally cover it, it's likely because it's not standard of care. And that's not what they're trying to do or trying to sell.
And
right?
they do that separately as like a
exactly.
I just wanted to be clear. They're not even
exactly. No, exactly. And so, again, I think it's like you said, it's a shattered system. And we, as physicians, are, especially those who are still working within hospital systems and have to, for whatever reason, are forced to see a certain number of patients or, given a certain amount of time to see patients. I'm fortunate that I am a subspecialist, so I actually get a little bit more of an extended period of time and can actually have these conversations with patients. But it's that patients want to feel like they've been listened to, right? And so it's, it's like the things we learned in medical school, sit down, even if it's for 2 minutes, like they feel like it's been much longer, right? Like, but that's what these other folks are selling to them. It's this idea that we're going to listen to you and give you this really personalized medicine approach. And yet it's vitamins that are probably just going to be urinated right out, like, to be perfectly honest, like it's just going to be really expensive urine, or hormones that are just not, that may or may not be what they're actually telling you you're getting, without potentially understanding the risks of it.
My dad used to say that Americans have the most expensive urine in the world, just to, finish that part.
I mean, the lists of supplements and vitamins that patients take now, where rather than eating their vitamins through a healthy diet or maintaining a healthy weight and reducing their risk of menopause, or reducing the risk of menopausal symptoms, even like a pellet is much easier, right?
Well, I think you're so right. And I think doctors need to make sure that we are giving patients what they need, because patients don't know credentials. They don't know that a lot of times the difference in training and education. What they do know is whether they're listened to, whether the person that's talking to them is compassionate and kind and showing empathy. The system does make that really hard for some of us to do, but we need to do our best to do that. And maybe some of us need to get out of the system that makes it impossible to show empathy, which is what I did in DPC. And just a little funny story about the meds. I do dispense medications in my little dispensary. And I was under a deposition for one of my patients is suing somebody. And so they deposed me, and they were trying to make me out like I make a lot of money off of patients. So they asked me about some medicine that I had given her, and they said, how much was that medicine? And I said, oh, that was $7. And they said, $7 per pill? And I said, no, $7 for 90 pills. And it just, they just couldn't answer that, because really it is about providing evidence-based care at an affordable price, and not, I wrote a mission statement for my practice, and I wrote a policy and procedure manual, which I recommend all doctors do. And in my mission statement, it's no gimmicks, because I need patients to trust me. I need them to believe in what I'm saying, that if I'm recommending something, it's because it's for their good and not because I'm personally profiting off of it. So I think that's really the key.
And, and I ask patients, I see a lot of patients with cancer, right, who are asking me about high dose vitamin D or high dose vitamin C, or, whatever the most recent thing that's out there in the lay press is. And I will always say, I was like, and how much is that person charging you for that infusion? Like, truly, right? Because it's, and I tell them that I tell them when there is evidence and when there isn't evidence. And so, yeah.
It's really important that we make sure patients understand. I guess that, to me, that's probably the most important point of this is just, I often tell people when I refer them to get a film or send them for a lab, I'm like, I don't get a penny out of this. And I'm so happy about that. And our vaccines are state supplied. So again, I really don't make money off of it. And I'm thrilled with that, because I think patients should ask, like you said, how much money are they getting out of recommending this? And if they're getting nothing, you can probably trust that's a fairly reasonable recommendation. So I think of all the things, if you feel like you're being sold, that's the time to ask questions, and that's the time to figure out if someone's profiting.
Yeah, it's so interesting how many people think that doctors make money off of giving vaccines. They don't realize that actually most doctors lose money when they give vaccines, or at best they just break even. So it's not a money-making operation for us.
It's funny because I often will give people websites or books to look at and things. And but I preface it by saying, I'm like, I have no stake in this game. Like, if you go there or don't, it doesn't matter to me. I don't know. I get nothing out of it, because I really don't want them to think that I have any other incentive except their health in mind.
And that's what we should have. And unfortunately, that's not what we're seeing with some of these hormone clinics. And I want to thank you very much, Dr. Joyce Varughese, for joining us to shed light on this issue. And hopefully patients will learn the kind of questions that they need to ask and make sure that they don't get taken advantage of, and that they can also save themselves from harm. If you'd like to learn more about this topic, we encourage you to get our book. It's called Patients at Risk: The Rise of the Nurse Practitioner and Physician Assistant in Healthcare. It's available at Amazon.com and at BarnesandNoble.com. We also would love for you to subscribe to our podcast and our YouTube channel. It's called Patients at Risk. And if you're a physician and you'd like to work with us more on getting the word out about physician-led care and truth and transparency among healthcare practitioners, we really encourage you to join our group. It's called Physicians for Patient Protection. You can visit our website, physiciansforpatientprotection.org. Thank you so much, and we'll see you on the next podcast.